Hi everyone, in this video I'll be discussing the therapy of benign prostate hyperplasia, the treatment of erectile dysfunction, and the treatment of prostate cancer. Very important, commonly asked questions in your exams. So let us start our journey. First of all, let us understand the drugs used in BPH. So drugs used in benign prostate hyperplasia. So the problem in benign prostate hyperplasia is the prostate gland has enlarged. Because it has enlarged, it is pressing on the prostatic urethra. So when it is pressing on the urethra, what happens? Patient is not able to pass the urine properly. Now, when the patient is not able to pass the urine, there is some residual urine remaining in the bladder. So because of that, he has to go to the toilet again and again. So you will have increased frequency, you will have urgency, and commonly that is seen in the patients who are elderly patients. So that's why it's important we have to give the drugs. Apart from drugs, what is there for BPH? We have surgery. But many times patient may not be willing for surgery, then we have to give the drugs. So what are the treatment for this? So let me write here. Drugs for BPH. We have two important modalities of treatment. The one which is acting faster, fast acting components. So they will work faster, and we have discussed them already, but it's a brush up now. The fast acting is, you know that the trigone of bladder and the prostatic urethral sphincter, they are supplied by alpha 1. So we can use alpha blockers which can work immediately and the urine can flow easily. In alpha blockers, we have two important therapies to use. The alpha 1 selective blocker, the alpha 1 selective blocker. So we have another category of drug which can block alpha 1A, that is specific for bladder. So alpha 1A selective blocker. Now when do you prefer this alpha 1 selective blockers? Suppose the patient has BPH as well as hypertension, because these drugs can take care of both prostate and they can take care of blood vessels also. So these are only for a patient with BPH only. These have no effect on PP. These have no effect on blood pressure. Okay, sir, what are these alpha 1 selective blocker you are talking about? They are prazosin. Prazosin. Then we have terazosin. So remember, they all end with zosin. Then doxazosin. Again, they end with zosins. Remember, these two drugs, terazosin and doxazosin, they have a specialty. They have quinazoline moiety. So it's a special structure in the drug, and that is responsible for prostate smooth muscle apoptosis. Very, very important point. Prostate smooth muscle apoptosis. Sir, is it good or bad? Very good. Why? Because BPH means prostate is enlarged. If the prostate smooth muscles are undergoing apoptosis, it's good only. So that specialty is seen with terazosin and doxazosin. So if a patient has hypertension and BPH both, then we can prefer it. There is one more alpha 1 selective blocker. The name is called alfuzosin. Alfuzosin is approved for BPH only. It is not for managing both BPH and hypertension. The name is called alfuzosin. It also ends with zosin. Now, many times what happens when we use these alpha blockers, the patient may develop hypotension frequently. And patient with these drugs may not like this because of repeated postural hypertension. So we have to shift the patients to the more specific drugs which can only act on the bladder. The name is called tamsulosin. Here they end with osin. One more drug is called sildeosin. Now, one important complication with tamsulosin, remember the adverse effect is floppy iris syndrome. Floppy iris syndrome. So it's an intraoperative complication. So before doing a cataract surgery, you have to stop these drugs. So we have discussed them already. And remember, these are the drug of choice for BPH. Though these are the drug of choice for BPH and they don't affect the blood vessels. Okay, they act faster. But we have another component. They are called slow acting components. They don't work in a week. They take at least months together to start working. They are called slow acting components. And what are they called as? They are called as 5 alpha reductase inhibitors. They are called as 5 alpha reductase inhibitors. Okay, so what are these drugs, sir? We'll discuss them now. So in managing BPH, we use a alpha blocker or we use 5 alpha reductase inhibitor. Alpha blockers are faster acting. The 5 alpha reductase inhibitors are slower acting. So what is this 5 alpha reductase? Now we know that testosterone is converted into dihydrotestosterone. And this conversion is done by the enzyme called 5 alpha reductase. Now, who is more efficacious is dihydrotestosterone. Now, when these levels are increased, it can increase the risk of BPH. It can also cause a baldness, and that is called androgenic alopecia. And in a female, if it is excess, it will lead to hirsutism. Suppose I want to treat all these three conditions. What should I use? So what should I do is to inhibit the 5 alpha reductase. If I inhibit that, the dihydrotestosterone level decreases and the treatment of these things can be done. So the BPH can be treated, androgenic alopecia can be treated, hirsutism can be treated. So 5 alpha reductase inhibitor, the name starts with finasteride. Very commonly asked question in exam, what is the mechanism of action of finasteride? It inhibits 5 alpha reductase. What happens if we inhibit that? The dihydrotestosterone level decreases and we can use it in treatment of each condition: BPH, androgenic alopecia and hirsutism. Now, these 5 alpha reductase are two subtypes of enzyme. So this will inhibit type 2 of 5 alpha reductase. So 5 alpha reductase are two types, type 1 and type 2. Finasteride inhibits mainly type 2. Similar to finasteride, we have one more drug. The name is called dutasteride. Now the specialty of dutasteride is it inhibits both type 1 and type 2 5 alpha reductase inhibitor, both. And it is approved for BPH only. Finasteride is approved for 3 conditions, but dutasteride is approved for BPH only. Sir, understood, fine. But the problem is, why are we using it in prostate? Will they work immediately? No. Then why are we using it? When you use them for a very long period, they have shown to decrease the size of prostate. They have decreased the prostate size. So this is one more important question they keep on asking in the exams. What drugs are known to decrease prostate size? That is finasteride and dutasteride. Very important. So that is about the 5 alpha reductase inhibitor. Even the topic is small, the questions keep on coming again and again. Another important condition which they keep on asking is the management of erectile dysfunction. So erectile dysfunction, what are the drugs we use? Number 1, we use the oral drugs. Now, what are the oral drugs used in the management of this problem? They are called as phosphodiesterase. PD stands for phosphodiesterase 5 inhibitors. Sir, what is the drug name? The drug name is avanafil. Then sildenafil. So remember they end with fill. Fill. Then vardenafil. Tadalafil. So why I've written like this? Because you can remember as PSVT. These drugs are ASVT drugs. But this is a shorter acting one, and tadalafil is a longer acting one. Long acting one. Okay, sir, fine. Sir, how do they do that erection? Now, please understand that. Now, mechanism of action of the drug is whenever there is stimulation of the nerves in the penile tissue, they can release nitric oxide. What happens? Nitric oxide stimulates an enzyme called soluble guanyl cyclase, and this will convert the glyceryl triphosphate into cyclic GMP. Now, this cyclic GMP will activate something called protein kinase G, which will cause vasodilation. Now, this vasodilation is responsible for the vasodilation in the penile structure. So, what happens there? The erection occurs. So, there will be penile erection. So, this is the normal physiology. Nitric oxide is released, which will activate guanyl cyclase. That will convert GTP into cyclic GMP. That is guanosine monophosphate. Then it will activate protein kinase G, vasodilation, and penile erection. So when this is normal, then why should we use drug? Certain people, this is not normal. Now what happens? This cyclic GMP is broken down into 5-GMP, and the enzyme which does that job is called phosphodiesterase 5. Now, if the penile erection duration should be increased, who has to increase? Cyclic GMP should increase. How do I do that? That can be done by inhibiting the enzyme phosphodiesterase 5. So what happens if I inhibit the enzyme? The cyclic GMP will be there for longer period, the vasodilation will be there for longer period, and the erection duration increases. So that is a mechanism of action of this sildenafil drugs. So that is the mechanism of action. But one important interaction they always ask is, can we combine sildenafil, tadalafil or whatever with nitrates? Yes or no? Remember, this will also increase the activity of cyclic GMP. Nitrate will also increase the activity of cyclic GMP. So what is the problem? When I combine them, there is severe fall in BP. So severe hypertension will happen. So never give them together. One of the commonly asked drug interaction, not only sildenafil, I am giving an example, any phosphodiesterase 5 inhibitor, when you give it nitrate, there is a risk of severe hypertension. Okay. Right. So coming to the pharmacokinetics, first thing you should tell the patient, these are not aphrodisiac. They don't increase the sexual pleasure or they don't increase the sexual desire. So they are only going to prolong the duration of erection. So they had to be given 1 to 2 hours before the sexual intercourse. Before sexual intercourse. Now I told you the drug interaction already. Now what is the adverse effect? Obviously the BP will fall sometimes. Now when the BP falls, there is reflex increase in heart rate. And number 3, patient may have a vision disturbance, that is blue tinted vision. So sometimes it is also given in the book as blue-green tinted vision. Now why the problem with vision? The problem is these are known to inhibit phosphodiesterase 6 in the retina. So that's the reason they can produce the blue-green tinted vision in certain people. And many a times the erection duration may get prolonged. So that is one more problem with these drugs. So recently they had asked the question, what is the mechanism of action of the sildenafil? And one more is sildenafil should not be used when nitrate. So we are discussing the drugs for erectile dysfunction. The first one is oral drugs. Once we know the oral drug, many a times I told you in testosterone concept, if the testosterone is lesser also there is loss of libido. So there may be replacement with testosterone, that is called androgen replacement, can be done. Now third important aspect is we use injections. So injectables. Now what is that injectable? Suppose the patient is having intercourse now. Before the intercourse, these are given into the penis. And then the patient is allowed to have sexual intercourse. The problem is injections are painful and patient will not accept that. That's a problem. So what are the drugs which are used locally for this? The name is called phentolamine and a opioid called papaverine and a prostaglandin. Any idea? It is called alprostadil. So these are injected locally for erection. Okay, so not all. Okay, any of these are injected locally. So we are done with management of BPH, erectile dysfunction. One more problem is they will ask in the exam is how do you manage premature ejaculation? Are there any drug approved for that? So premature ejaculation is the condition where the person will ejaculate early and the drugs are SSRIs. Why SSRIs are preferred? Because they delay the ejaculation process. So what is the SSRI of choice? There are two SSRIs. One is called duloxetine. So duloxetine is the FDA approved one. And one more which is used off label is paroxetine. But mainly you have to remember the name duloxetine is mainly used. So duloxetine has P, paroxetine has P, so they are for premature ejaculation. TCA, a drug of TCA class, cloimipramine, is also being tried for premature ejaculation because cloimipramine has serotonergic property more. That's the reason. So once we understand this, let us understand another important aspect is the hormonal therapy of prostate cancer. So prostate cancer, usually we do surgery, but many a times surgery may not be possible. In prostate cancer, so what we need to know is it is a hormone dependent cancer. So testosterone dependent cancer. So what we have to do, we have to stop the production or we have to block them. So number one therapy what we have is the androgen receptor blockers. So we have androgen receptor blockers. So what are the androgen receptor blockers we use it? They all end with glutamide. So flutamide. Then we have another drug, bicalutamide. Then we have enzalutamide. Then we have nilutamide. So my purpose is to tell you, in your exam, you need not buy out all the drugs. Remember, if they are ending with lutamide, they are androgen receptor blockers. All these are approved for prostate cancer. They are all approved for prostate cancer. Now, flutamide, apart from this, is also approved for two more conditions in acne and in the management of hirsutism. Apart from that, all the drugs are used for prostate cancer. So all are used for prostate cancer. So number one therapy is androgen receptor blockade. Number two therapy is we use GnRH agonist. We have discussed these drugs already in the hypothalamus pituitary topic. Let me give an example of this GnRH agonist. For example, leuprolide, then goserelin. So this can be used. But the question is, when you are giving GnRH agonist, are we give it intermittent or continuous? So obviously you have to keep that in your mind. It is given continuous. Don't give it pulsatile. If you give it, cancer will flare up. Now another therapy for prostate cancer is GnRH antagonist. So you can give GnRH antagonist, and you know that they end with LIX. For example, AVA relix, again it ends with a relix, then DAGA relix. So these are GnRH antagonists that is also used in prostate cancer. Now another important therapy which is also being tried in prostate cancer, the name is called abiraterone. The name is called abiraterone, and remember abiraterone inhibits the androgen synthesis by blocking 17 alpha hydroxylase. So it acts by inhibiting 17 alpha hydroxylase enzyme. So these are the therapies what we have for prostate cancer. Let me repeat them. One is androgen receptor blockers. They end with lutamide. GnRH agonist should be given continuously. GnRH antagonist, they end with LIX. Abiraterone, which is an inhibitor of 17 alpha hydroxylase, these are all used. Now, one important thing I just want to discuss, one application part. Now, what happens when you give GnRH agonist continuously? When we give GnRH agonist continuously, what happens? Initially, what happens? They will increase FSH and LH. And what happens? They increase the testosterone and increase the estrogen. Sorry, mainly I'm discussing in a male testosterone. So what happens if the testosterone increases? It can cause cancer flare up. The cancer may get flared up. So later what happens? The receptors are desensitized. They are desensitized. So what happens? That will lead to decrease in FSH, LH, and decrease in testosterone. This is later, but we don't want the cancer to flare up. So what to do now? To avoid this cancer flare up, what we do is we use the drug flutamide. So when we use flutamide, this is given 3 days before giving GnRH agonist, and then we give GnRH agonist. So this strategy will prevent the cancer flare up. So when we give testosterone, when we give this GnRH agonist continuously, testosterone increases. So that can be blocked by flutamide, and the cancer flare up will not occur. So this is called combined androgen blockade. Combined androgen blockade. Right. So flutamide has to be started 3 days before, so cancer flare up will not occur. Now one more concept I just want to tell you. One more concept is, can I give flutamide alone in prostate cancer? Again, a rational question. Flutamide alone in prostate cancer. What happens if I give? What is the role of flutamide? It blocks the testosterone receptor. So it's a androgen, means testosterone receptor blocker. Yes or no? Now what happens when I start this in a patient with prostate cancer? So we know that hypothalamus, pituitary, and the testis. Now when I use a blocker, there is a receptor for negative feedback mechanism. So whenever the testosterone increases, there is a negative feedback mechanism here. Now when I use flutamide, what happens? What happens when I use flutamide? The flutamide will block the testosterone receptors in the hypothalamus and pituitary. When they block that receptor, what happens? The negative feedback is not there, so there is increase in testosterone. So there is increase in testosterone production. Now what happens when the testosterone is high? When the testosterone is high and the flutamide is blocking the testosterone receptor in the prostate. So this is the prostate and we have given flutamide, it is blocking that. This testosterone which is high will kick the flutamide out and flutamide will come out and testosterone will work on the prostate. So I cannot give flutamide alone for managing prostate cancer also. The reason I will tell you again. What happens normally? We have hypothalamus, pituitary, and organ axis. So testosterone acts on the receptor in hypothalamus, pituitary, and it has negative feedback. Now, when I start flutamide, what happens? The negative feedback is not seen because it will block the receptors, testosterone receptor in the hypothalamus, pituitary. So testosterone release increases. Now, when it is more, it will replace the flutamide from the prostate, and prostate cancer may flare up. So, because of this reason, along with flutamide, we need to give GnRH agonist. So, when I give GnRH agonist continuously, they will desensitize the receptor here. So, when they desensitize the receptor, the testosterone will not get released. So, that's the reason why the combination should be given. The combination should be given to avoid this problem. So, never use flutamide alone, never use GnRH agonist alone in the initial days. So, these are the strategies what you need to understand here. Okay, the point to be taken here is you have to give them together. So, if you give flutamide alone, testosterone increases, displaces flutamide, and it will not work. If you give GnRH agonist alone, it will cause cancer flare up. That's the point. So, the last important is what are the drugs causing gynecomastia? So, very commonly asked in your exam, drugs causing gynecomastia. So the mnemonic is in moving and dashing car, Skoda. So what is this in moving dashing car Skoda? In for the isoniazid used in TB, M for methyl dopa, and an antiemetic drug, metoclopramide, and D for domperidone, again an antiemetic, C an antihistamine. What is it called? Cimetidine. Yes, an a diuretic spironolactone, an antifungal ketoconazole. Now, what happens if you give estrogen in a male? Again, gynecomastia. Digoxin and any drug which is anti-androgens can do this job. So, these are the drugs which are known to cause gynecomastia. INH, methyl dopa, metoclopramide, domperidone, cimetidine, spironolactone, ketoconazole, estrogen, digoxin, anti-androgen. So, at the end of this video, concluding the important aspect. So, BPH, there are two important drugs we use it. Alpha blocker, they are faster acting, and tamsulosin, sildosin, they are the drug of choice for BPH. They don't produce hypertension. The slower acting ones are 5-alpha reductase inhibitors. They inhibit the conversion of testosterone to dihydrotestosterone. The level of dihydrotestosterone decreases. Now, why are we using it? Because they decrease the prostate size. Now, once the BP is done, the drugs for erectile dysfunction, they are phosphodiesterase 5 inhibitor. What happens when you inhibit that? They increase the cyclic GMP, which will cause vasodilation and increase the penile erection duration. Don't give them with nitrates, severe fall in BP. The injections are phentolamine, papaverine, and one more is alprostadil. The next important aspect is we can do androgen replacement therapy also. Premature ejaculation, SSRI of choice is dapagliflozin. Then prostate cancer, we have androgen receptor blocker. They end with lutamide. Flutamide is also used in acne and hirsutism. And then we have the GnRH agonist, which are used continuously, but there is a risk of flare-up. So we add flutamide before that to avoid flare-up. Don't give flutamide alone because testosterone feedback is blocked. So testosterone can get released and displace flutamide. So there is a risk. So always combine GnRH agonists with glutamides. Apart from that, we have GnRH antagonists. They end with lix, abarelix, ganarelix, degarelix, and we have a 17 alpha hydroxylase inhibitor that is called abiraterone. And also we have discussed drugs causing gynecomastia. So that's it with this video. Thank you all.